Okay, let's talk about Module 8, endocrine overview. This module reviews the clinical use of hormones and hormonal analogs that function as agonists or antagonists and are used to treat metabolic and hormonal problems. The pharmacological treatment of common endocrine problems such as diabetes, thyroid disorders, and testosterone deficiency, along with rheumatoid arthritis, osteoporosis, erectile dysfunction, and obesity. This module is divided into 5 units: diabetic medications, thyroid disorders, testosterone deficiency, and erectile dysfunction. Unit C, osteoporosis. Unit D, glucocorticoids and DMARDs. Unit E, obesity treatment. Unit A, diabetic medications. For type 1 diabetes, result of autoimmune-induced pancreatic beta cell destruction with resulting insulin deficiency, usually occurs in persons younger than 30 years of age. A symptomatic presentation: involuntary weight loss, polyuria, polydipsia, polyphagia, can present with ketoacidosis, dehydration, abdominal pain, vomiting, decreased level of consciousness. Lifelong insulin therapy is needed. Typically, basal insulin and boluses of short-acting insulin to provide coverage for mealtime and snacks. Insulin resistance and type 2 diabetes, genetically predetermined and environmentally modified condition. Reduced tissue sensitivity to insulin. Hyperglycemia occurs which stimulates pancreas to produce insulin. Euglycemia results as a result of hyperinsulinemia. After many years of insulin resistance, pancreatic beta cell deficiency occurs, resulting in impaired glucose tolerance, hyperglycemia, and type 2 diabetes. Patients are often asymptomatic at onset, the American Diabetes Association (ADA) recommends screening adults every 3 years or earlier if risk factors. Diagnostic tests: hemoglobin A1C. Normal is less than 5.7, pre-diabetic 5.7 to 6.4, and a diagnosis of diabetes will be greater to or equal to 6.5. Fasting plasma glucose: normal is less than 100, pre-diabetic 100 to 125, and equal to or greater than 126 equals diabetes. Random plasma glucose: less than 130 is normal, pre-diabetic between 130 and 199, and diabetic equal to or greater than 200. Oral glucose tolerance test: 2 hours after a 75-gram oral glucose load should be less than 140. Pre-diabetic, it's 140 to 199. And if diabetic, it's equal to or greater than 200. So early treatment. Treat early for patients with impaired glucose tolerance, impaired fasting glucose, hemoglobin A1C of 5.7 to 6.4%. Treatment includes a lifestyle prescription for weight loss if needed, dietary education, ideally with a diabetes instructor or nutritionist, and physical activity for at least 150 minutes a week. Early treatment with metformin, only drug in RCTs that has been shown to decrease mortality and diabetic complications. No medications, either weight loss drugs or anti-hyperglycemic agents, are currently approved by the FDA solely for the management of prediabetes and/or the prevention of type 2 diabetes. Diabetic control means tailoring the glycemic goals to each patient. Maintaining low A1C levels helps to prevent some complications, yet very tight control increases the risk of hyperglycemia. For most patients, an A1C of less than 7 as the goal, but some patients may have a goal of less than 8. If your patient is not adherent due to hypoglycemic episodes or feels that reaching an A1C of less than 7 is futile, aim for a number around 8 or lower. There is also the concern that lowering A1C levels in patients with long-standing diabetes who are older and with a high risk for cardiovascular events may have an increased risk for cardiovascular events if A1C lowers too rapidly or too low. An A1C in the 6% to 6.5% range may reduce microvascular complications such as retinopathy progression and albuminuria, yet the increased incidence of hypoglycemic episodes increases in this range. It has also not been established that tight control will prevent visual loss or nephropathy. Insulin therapy is required for the treatment of type 1 diabetes. Insulin is a protein, and proteins are digested in the stomach. Therefore, insulin is not bioavailable when given orally. It must be given by injection or intravenously. All insulin is now synthetic insulin. Beef and pork insulin is no longer manufactured in the U.S. Insulin is given sub-Q. Consistency and rotation of sites is recommended. For example, morning sub-Q, injections in the abdomen, evening in the buttocks. Site selection is based on the different rates of insulin absorption. The most common area for injection is the abdomen, followed by outer back of arms, outer thighs, and the buttocks. Be very careful adjusting insulin in type 1 diabetes. These patients produce no endogenous insulin and are therefore very sensitive to dosing adjustments. The most commonly used types of insulin preparations based on the duration of action are rapid-acting insulin, immediate treatment of blood glucose levels, used in insulin pumps, such as Lispro, which is Humalog, Aspart, which is Novolog, Glulisine, which is Apidra. The onset is 5 to 15 minutes. The peak is 0.75 to 3 hours, and it lasts 3 to 5 hours. Short-acting insulin is regular insulin. It's Humulin R and Novolin R. Onset is 15 to 30 minutes. Peak is 2 to 4 hours. Duration is 5 to 8 hours. Intermediate is NPH, Humulin N, Novolin N. Onset in 1 to 2 hours. Peak is 4 to 12 hours. Duration is 18 to 24 hours. Long-acting or basal insulin, Gargline or Lantus, and Determere, which is Levemir, given once daily. Onset is 1 to 2 hours. Peak none to 4. Duration 24. Intermediate acting combination preparations are Novolog mix 70-30, Humalog mix 75-25, another Humalog mix 50-50, Humulin 70-30, and Novolin 70-30. The onset is 30 minutes, peak is 0.5 to 12 hours, duration up to 24 hours. Agents for treatment of type 2 diabetes. Oral hypoglycemic agents are sulfonylureas, metformin, thiazolide, lidinones, alpha-glucosidase inhibitors, and actions of oral hypoglycemics stimulate the pancreas to release insulin, such as sulfonylureas and meglitinides, enhances receptor sensitivity to insulin, such as biguanides and sulfonylureas, Inhibits liver production of glucose, gluconeogenesis, and liver breakdown of glycogen into glucose, which is glycolysis, and biguanides, such as biguanides. Inhibits the enzyme alpha-glucosidase, which causes a decrease in intestinal secretion of glucose. Alpha-glucosidase inhibitors increase sensitivity to insulin in the skeletal muscle. Thiazolidine andiones increase insulin resistance, reduce glucagon release, decrease hepatic glucose production, such as gliptins or DPP-4 inhibitors. Biguanides would be metformin or glucophage. This is a first-line drug. Metformin has been used in Europe for over 30 years, but has been available in the US since March 1995. It is effective only in the presence of insulin, but in contrast to sulfonylureas, does not directly stimulate insulin secretion. Its major effect is to increase insulin action. Exact way metformin increases insulin action is not known, but one important effect appears to be suppression of glucose output from the liver. It also enhances receptor sensitivity to insulin in muscle and fat, slightly reduces glucose absorption in the gut. It typically lowers fasting blood glucose concentrations by approximately 20%, which is similar to sulfonylurea. It is less likely to cause hypoglycemia than a sulfonylurea. Also lowers serum triglycerides, free fatty acid concentrations, and LDL levels, raises HDL. The initial agent to reduce microvascular complications, helps with weight regulation, and reduces the risk of cardiovascular events. Clinical use, it's also used in polycystic ovary syndrome. Type 2 diabetes mellitus. It's often used in patients with type 2 diabetes who are obese because it promotes modest weight reduction or at least stabilization. This is in contrast to the increased appetite and weight gain often induced by insulin and sulfonylureas. Non-FDA indications is prediabetes. Efficacy, evidence favors efficacy. Disadvantage, there's a risk for lactic acidosis and prominent gastrointestinal side effects. Pharmacokinetics, take with meals, start at a low dose to avoid intestinal side effects. Dose can be increased as slowly as necessary to a maximum of 2,550 milligrams per day, which is 850 milligrams TID. Side effects, the most common are gastrointestinal, such as having a metallic taste in the mouth, mild anorexia, nausea, abdominal discomfort, diarrhea. Symptoms are usually mild, transient, and reversible after dose reduction or discontinuation of the drug. A rare problem is lactic acidosis, which is considered a black box warning. May be fatal in up to 50% of cases. Serious lactic acid accumulation usually occurs only in the presence of a predisposing condition, including renal insufficiency, current liver disease, or alcohol abuse. Heart failure, past history of lactic acidosis, severe infection with decreased tissue perfusion, hypoxic states, serious acute illness, hemodynamic instability, age 80 or more. Onset of metformin-induced lactic acidosis may be subtle and include nonspecific symptoms such as malaise, myalgia, respiratory distress, somnolence, and abdominal distress. Lab values include low pH, increased anion gap, and elevated blood lactate levels. Increased risk associated with renal or hepatic impairment. age 65 years or older, having a radiological study with contrast, surgery, or other procedures, hypoxic states, and excessive alcohol intake. Monitoring is recommended in these situations. Discontinue metformin at time or before any radiologic procedure involving the administration of iodinated contrast material into the blood. May need to hold metformin for 48 hours after administration of IV contrast. Reevaluate eGFR 48 hours after imaging procedure. Restart if renal function is stable. The rationale for this recommendation is to avoid the potential for high plasma metformin concentrations if the patient develops contrast-induced acute renal failure. Discontinue metformin if lactic acidosis is suspected and initiate supportive measures. Monitoring renal function, eGFR, prior to therapy initiation and at least annually, more often in patients at risk for developing renal impairment. Contraindicated in severe renal disease, which is an eGFR of less than 30 ml per minute / 1.73 m2. Acute or chronic metabolic acidosis, including diabetic ketoacidosis with or without coma. Hypersensitivity to metformin. Drug interactions. Potential drug interactions exist between metformin and cimetidine or Tagamet, resulting in an increase in metformin blood levels. Remember, Tagamet has numerous drug-to-drug interactions. It can increase the risk of hypoglycemia in patients taking metformin plus a sulfonylurea or insulin, and could increase the risk of lactic acidosis in those with impaired renal function. The sulfonylureas, most widely used drugs for the treatment of type 2 diabetes. They function by stimulating insulin secretion. The net effect is increased responsiveness of B cells, insulin-secreting cells located in the pancreas, to both glucose and non-glucose secretagogues. Results in more insulin being released at all blood glucose concentrations. Have extra pancreatic effects, which increases tissue sensitivity to insulin. Not contraindicated in individuals with a sulfa allergy, as the sulfonamide component in the typical sulfa antibiotic is of a different molecular structure than that found in sulfonylureas. Understanding sulfa allergies. Sulfur is found in drugs and preservatives in various forms, including sulfites, sulfates, sulfhydryls, and sulfonamides. Sulfonamide drugs are further differentiated into those with arylamine groups, sulfonylaralamines, and those without. Sulfonamide antibiotics are among the most frequent causes of adverse drug reactions. However, the hypersensitivity is known to be associated with arylamine moiety. Therefore, no cross-reactivity would be expected between sulfonamide antibiotics, sulfonylamines, and other non-arylamine sulfonamides. While a small number of cases of possible cross-reactivity have been reported, these appear due to allergic susceptibility of the patient rather than a true cross-reactivity. Therefore, non-antibiotic sulfonamide drugs are generally not considered as contraindicated in those with a history of hypersensitivity to antibiotic sulfonamides, which are the sulfonyluramines. Because of this, and the variety of sulfur-containing drugs, use of the term sulfur or sulfa allergy is imprecise and should be avoided. Pharmacokinetics. Sulfonylureas differ mainly in their potency and the duration of action. Glypizide, glyburide, which is glibenclamide, and glimepiride are so-called second-generation sulfonylureas. They have a potency that allows them to be given in much lower doses. Those with longer half-lives, particularly chloropropamide, glyburide, and glimepiride, can be given once daily. This benefit may be counterbalanced by a substantially increased risk of hypoglycemia. Side effects are usually well tolerated. Hypoglycemia is the most common effect and is more common with long-acting sulfonylureas. Patients recently discharged from the hospital are at highest risk for hypoglycemia. Patients should be cautioned about settings in which hypoglycemia is most likely to occur: after exercise or a missed meal when drug dose is too high, with the use of longer-acting drugs such as glyburide or chloropropamide, in patients who are undernourished or abuse alcohol, in patients with impaired renal or cardiac function or intercurrent GI disease, with concurrent therapy with salicylates, sulfonamides, fibric acid derivatives such as gemfibrozole and warfarin, after hospitalization. There are infrequent side effects of nausea, skin reactions, abnormal liver function tests, and weight gain. Clinical use: lowers blood glucose concentrations by 20%, most effective in patients whose weight is normal or slightly increased. In contrast, insulin should be used in patients who are underweight or losing weight or are ketotic, despite adequate calorie intake. Choice is dependent upon cost and availability. Efficacy is similar. Shorter-acting drugs should be used in elderly patients due to risk of hypoglycemia. C-gliptins are DPP-4 inhibitors, also called incretin enhancers. Linagliptin, which is Tradjenta, saxagliptin, which is Onglyza, and sitagliptin, which is Januvia. Inhibits degradation of endogenous incretins, which increases insulin secretion, decreases glucagon secretion, and decreases hepatic glucose production. They are weight neutral, considered third-line therapy in patients with A1C greater than 9%. Thiazolidines, which are glitazones such as Actos, pioglitazone, and rosiglitazone, which is Avandia, reverse insulin resistance by acting on muscle, fat, and to a lesser extent liver, increase glucose utilization, and diminish glucose production, redistribute fat from visceral compartment to sub-Q compartment. We know that visceral fat is associated with insulin resistance. There have been reports of severe liver injury in small numbers of patients receiving Resilin, which has been removed from the market. Most cases of liver damage occurred early in treatment with the drug and were reversible when it was stopped, although some deaths have occurred. The newer agents, Actos and Avandia, have a much lower incidence of this side effect. Emeglitinides. Repaglinide is Prandin, or nataglinide is Starlix. These stimulate insulin release from beta cells taken with meals and are beneficial for patients with erratic meal schedules, as well as those with normal fasting plasma glucose readings but high postprandial blood glucose levels. Have a rapid onset and short half-life, so that risk of hypoglycemia is less than with some of other hypoglycemic agents, often used in combination with metformin. Some sources indicate this is a weight-neutral drug, while other sources state there is weight gain. Third line recommendation. Side effects: bloating, abdominal cramps, diarrhea, flatulence. Recommended as add-on therapy if A1C is 6.5 to 9%. Then there are alpha glucosidase inhibitors. We have acarbose, which is precose, miglitol, which is glycet. These are infrequently used due to intolerable side effects. These inhibit the upper GI enzymes that convert dietary starch and other complex carbs into simple sugars, which can then be absorbed. The result is to slow absorption of glucose after meals. The advantage is that they work in the gut, so there is little hypoglycemia. These drugs only affect postprandial blood sugar levels, so they are taken with the first bite of each main meal up to 3 times a day. This class of drug will be better tolerated if the client also decreases sugar. Side effects: flatulence, diarrhea, usually mild and does not necessitate discontinuation. Other options would be bile acid sequestrant, colesevelam, which is Walchol, and dopamine agonist, bromocriptine, which is cyclicet. So then we have the non-insulin injectable hypoglycemic agents. There are 2 non-insulin injectable hypoglycemic classes of drugs for the management of type 2 diabetes. There's GLP-1 agonists, which are incretin mimetics and amylin analogs. There's GLP-1 agonists, incretin mimetics, exenatide, Byetta, and liraglutide, Victoza. They mimic hormones that help regulate blood glucose by stimulating GLP-A receptors, which stimulate insulin release. They inhibit postprandial glucagon release, slowing gastric emptying. Side effects are nausea, hypoglycemia, possible weight loss. Then there's an amylin analog, pramlintide, which is Simlin, and frequently used due to intolerable side effects. Slows gastric emptying, leading to a feeling of early satiety. Decreases postprandial glucagon secretion. Side effect is hypoglycemia and nausea. May promote weight loss, but is considered third line due to lack of efficacy in lowering blood sugar substantially when considering cost. Used as an adjunct to insulin. For the management of type 2 diabetes, if A1C equal to greater than 6.5%, or fasting plasma glucose equal to or greater than 126 milligrams per deciliter, or random plasma glucose equal to or greater than 200, with symptoms of hyperglycemia, and 2-hour plasma glucose equal to or greater than 200 during an oral glucose tolerance test. For the initial drug monotherapy is metformin, if necessary to reach A1C target after 3 months. You can use a 2-drug combination with metformin. SU-TZD, DPP-4 inhibitor, GLP-1 receptor agonist, insulin, basal. If necessary to reach A1C target after 3 months, add a 3rd drug not already part of the patient's regimen from the following list: SU-TZD, DPP-4 inhibitor, GLP-1 receptor agonist, insulin, basal. If necessary to reach A1C target after 3 months, use more complex insulin strategies. A1C goals, hemoglobin A1C goals. Differing opinions between ADA and ACE. According to ADA guidelines, the standard A1C goal for adults with type 2 diabetes is 7%, but this can vary depending on individual patient profiles. The ACE recommendations are more aggressive, with a target A1C of equal to or less than 6.5% to minimize risk of diabetic complications. Pregnancy and lactation. Pre-gestational diabetes. The preconception period is the ideal time to establish euglycemia, preferably several months before conception. When blood glucose levels are controlled several months before conception, the woman and her fetus will be exposed to fewer risks, including major congenital anomalies and miscarriage. Treatment includes diet, exercise, medication when necessary. Depending on her individual situation, plans for conception, and contraceptive status, the provider must consider medications known to be safe in pregnancy. For those women who are already diabetic, medication adjustments during pregnancy are often required due to the propensity for hypoglycemia in pregnancy and the damaging effects of both hyper and hypoglycemia. Gestational diabetes. In any given group, the prevalence of gestational diabetes is directly correlated with that of type 2 diabetes. Globally, gestational diabetes is on the rise for the same reasons. Type 2 diabetes is on the rise. Poor diet, sedentary lifestyle, and an increase in overweight and obesity. Gestational diabetes, as with type 2 diabetes in the general population, is a form of carbohydrate intolerance that may occur under two physiologic circumstances. Either the woman was an undiagnosed diabetic before pregnancy and is diagnosed for the first time during prenatal care, or she becomes diabetic for the first time during pregnancy and is thus diagnosed during prenatal care. Significant maternal and fetal risks are associated with GDM. The normal physiologic and hormonal changes of pregnancy can cause insulin resistance and reduced insulin effectiveness. When these hormonal changes are in balance and the woman is not diabetic, this physiologic change is inherently protective to the fetus and ensures adequate caloric deposition to the feto-placental unit. But for those women who are diabetic, these changes cause higher than normal amounts of glucose to be transported from the maternal system to the placental and fetal systems, resulting in hyperglycemia. Euglycemia significantly reduces those risks, therefore prevention when possible and strict control are critical. GDM and medication. There's good news. Those who follow a diabetic diet and maintain regular exercise often avoid the need for medication. Nutrition and exercise counseling, dietary modifications, appropriate exercise regimen, and glucose monitoring are the first step in GDM management. If diet and exercise don't adequately control glucose levels, medications are needed. Two pharmacologic drug classes are available for safe use in pregnancy: parenteral insulin and oral anti-diabetic medications, metformin, which is glucophage, and glyburide. Insulin is considered gold standard due to its long-term safety profile and inability to cross the placenta. According to the American College of Obstetricians and Gynecologists, oral anti-diabetic medication should be considered only if the pregnant woman declines insulin or if the provider determines that safety issues with insulin administration outweigh its benefits. If an oral agent is necessary, metformin, a biguanide, is the best choice. Glyburide, a sulfonylurea, is no longer recommended due to its ineffectiveness. It is also contraindicated in those women with a sulfa allergy. Oftentimes, the oral medications are the most popular choice due to their ease of use and growing safety profile, even though they have not yet been approved by the FDA for use in gestational diabetes. This is another example of off-label use supported by literature, and they do not cross the placenta. Even so, patients must be educated and informed of insulin safety profile and rationale for use as a first-line recommendation for gestational diabetes. Subcute insulin requires collaboration with or referral to an obstetrician or a maternal fetal medicine specialist. Oral medications. The first generation sulfonylureas are contraindicated during pregnancy due to fetal hyperinsulinemia. The second generation sulfonylurea glyburide, or diabeta-micronase or glinase, does not cross the placenta but has been associated with fetal effects as severe as the first generation. However, second generation is associated with increased risk of fetal hyperinsulinemia and maternal hypoglycemia. While Category C, overall, this oral hypoglycemic agent is considered safe in pregnancy, and maternal fetal outcomes are similar to those with insulin use in pregnancy. Metformin, a biguanide or glucophage, as with glyburide, there is growing evidence that metformin is likely safe and effective during pregnancy and is a Category B. Some data suggest that metformin may be the optimal oral anti-hyperglycemic for overweight or obese women, and it's not associated with fetal hyperinsulinemia and maternal hypoglycemia. Lactation. In general, successful breastfeeding is undeterred in diabetic mothers. As in pregnancy, euglycemia is important. Glycemic control supports the hormonal processes of lactation, and normal blood glucose enables the maternal prolactin release necessary for lactation. Normal insulin levels are also needed for successful lactation. Human insulins, NPH, and regular human insulin are considered safe with breastfeeding. There are no reported adverse reactions, and newborn exposure to insulin in breast milk may help prevent type 1 diabetes in these infants. Other insulins: aspart, detamir, glargine, glulisine, lispro. While they are probably safe, caution is advised for the use of the newer biosynthetic insulins with breastfeeding due to limited studies. If you have the Brucker and King text, see the helpful chart in the lactation chapter on insulin preparations and their safety with breastfeeding. Moving on to Mod Unit B, thyroid disorders, testosterone deficiency, erectile dysfunction. Thyroid disorders. The thyroid hormones regulate intermediary metabolism of carbohydrates, fats, and proteins. They regulate growth and cardiovascular function. Hyperthyroidism may be caused by thyroid-stimulating antibodies directed against receptors at the surface of the thyroid cell, which is called Graves' disease, may be due to TSH-secreting tumors, and results in a hypermetabolic state. Symptoms include tremor, tachycardia, tachypnea, heat intolerance, exophthalmosis, pretibial edema. A treatment is aimed at normalizing thyroid hormone production, minimizing symptoms, and decreasing complications. Treatment also may be initiated to achieve a euthyroid state prior to surgery. Antithyroid treatment includes surgical ablation of thyroid tissue or antithyroid medications. Propylthiouracil block the thyroid hormone synthesis. Methimazole has a similar mechanism of action to PTU, but with different pharmacokinetics. All of these will be most commonly initiated by an endocrinologist. APNs often initiate propranolol or Inderal to treat the symptoms of tachycardia, tremor, and anxiety until a euthyroid state is achieved. Hyperthyroidism, pregnancy, and lactation. Note FDA pregnancy risk categories for propylthiouracil and methimazole both are Category D. Nonetheless, endocrinologists will prescribe propylthiouracil due to maternal and fetal risks associated with untreated hyperthyroidism. Propylthiouracil is preferred since it is highly protein-bound, which results in less transfer of the drug to the placenta and fetus. Both propylthiouracil and methimazole are considered compatible with breastfeeding, with propylthiouracil being the safer of the two. Hypothyroidism is characterized by hypometabolic state. Resulting symptoms include lethargy, fatigue, weight gain, skin changes, cold sensitivity, constipation, hypolipidemia, bradycardia. Treatment goals: replace missing thyroid hormone, normalize thyroid-stimulating hormone levels. Thyroid replacement therapy is synthetic. At one time, desiccated thyroid was used, but it has been almost entirely replaced by synthetic thyroid preparation, such as Synthroid or levothyroxine. Anticipated dose for an adult is 75 to 125 micrograms levothyroxine, or about 1.6 micrograms per kilogram per deciliter of ideal body weight. Elderly patients often require 20 to 25% less per kilogram than younger patients due to decreased body mass. As this drug has 5 to 6 drug half-lives, a recommended testing interval post-adjustment change is 6 to 8 weeks. According to AACE 2012 guidelines, TSH should be kept between 0.45 and 4.12 mu per L. Most patients feel optimal and function optimally when TSH is between 1 and 2. Once TSH is stabilized, check at 6 months and 12 months intervals. Patient education: take at the same time every day. Take after rising on empty stomach with full glass of water. Do not eat for at least 1 hour after taking, or 4 hours after eating, and wait for 1 hour before eating. Hypothyroidism, pregnancy, and lactation. The fetus relies on the mother for thyroid hormone until after the first trimester. Insufficiency can lead to profound fetal effects, such as compromised fetal brain development. Levothyroxine, which is synthetic T4, is category A and considered first-line treatment for hypothyroidism in pregnancy. If a woman is already taking thyroid replacement, note that dosage requirement significantly increase in pregnancy and that regular monitoring of serum TSH is necessary. Levothyroxine is also considered safe with breastfeeding. Testosterone deficiency. You have probably heard commercials promoting testosterone replacement therapy, TRT, for men. Testosterone deficiency is considered primary if it is testicular in origin, and secondary if arising from a hypothalamus pituitary dysfunction. It is estimated that 14 million men greater than 45 years of age who visit a primary care provider may have a testosterone deficiency. Due to the aging population and the numbers of baby boomers who are moving into the ranks of senior citizens, increased focus is on health with aging. The increase in testosterone is marketed to the public that with an increased T, there is improved sexual function, mood, muscle mass. Whether men actually need testosterone replacement with advanced age is not clear. However, treatment for those men with lower than normal testosterone levels can improve sexual, physical, and psychological health and increase energy. Use is approved in men with hypogonadism, which can occur before or after puberty. Often, providers have been reluctant to prescribe testosterone due to concerns with increased risk of prostate cancer. Comorbidities include metabolic syndrome, diabetes, cardiovascular disease, hypertension, COPD, autoimmune diseases. To make a diagnosis, it is recommended that an LH level and a total testosterone level be drawn in the morning after an overnight fast, with values below normal on 2 different occasions. Risk benefits of therapy. The treatment goal is to increase the quality of life, which may be by increased libido, enhanced mood, and improved bone and muscle mass. There are few well-controlled studies on the impact of testosterone replacement in aging. Testosterone increases hematocrit, HCT, which can lead to polycythemia. Replacement therapy may also increase the risk for benign prostatic hyperplasia and prostate cancer. There is also a risk for increased lipids with testosterone replacement, particularly an HDL increase. Patients with hypertension may see an increase in blood pressure due to fluid and sodium retention. A positive benefit for diabetics is that blood sugar may be lowered. Adverse effects: worsening sleep apnea, gynecomastia, acne, accelerated male pattern baldness. Testosterone replacement formulas. Oral is not recommended. There's long-acting injectable. There's buccal tablets, transdermal, which is preferred in elderly men due to convenience and reversible action. There's topical gel. Pellets, which can be implanted subcutaneously at 3 and 6 month intervals. There's prostate and breast cancer, which are absolute contraindications for testosterone replacement therapy. While on testosterone replacement therapy, PSA levels should be performed quarterly during the first year, then annually. A digital rectal exam should be performed every 6 months. Total testosterone levels should be measured every 3 months. Hematocrit values of greater than 54% require discontinuation. Erectile dysfunction is a persistent inability to maintain and sustain an erection sufficient for intercourse. Although there are several methods to treat ED, the most commonly utilized is pharmacologic. Oh my goodness. Physiology of erectile dysfunction. The penis becomes erect after sexual stimulation, which occurs as a result of the release of nitric oxide. This results in the dilation of blood vessels in the corpus cavernosum. The dilation is due to the accumulation of the cyclic guanosine monophosphate. The enzyme that breaks down guanosine monophosphate, which is GMP, is PDE5. PDE5, which is phosphodiesterase type 5, causes vasodilation in the penis and the lungs by blocking the breakdown of GMP, which results in prolongation mediators causing vasodilation, including nitric oxide. PDE5 inhibitors prolong erection and decrease pulmonary vascular pressure. There is little impact on the systemic vasculature. Mechanism of action of PDE5 inhibitors. PDE5 inhibitors block the action of the enzyme PDE5 that breaks down GMP, thereby enhancing the vasodilatory effects of nitrous oxide. Because the medication acts only in the presence of PDE5, the medication does not have an effect on the penis until sexual stimulation occurs. PDE5 inhibitors, or Revatio, are also used to treat pulmonary hypertension. Each of the PDE5 inhibitors on the market target different isozymes. Research has not demonstrated significant differences in the products currently on the market, such as sildenafil, tadalafil, vardenafil, avanafil. Patient education: take PO 1/2 to 4 hours before intercourse and no more than once daily. Sildenafil and vardenafil have delayed absorption by 1 hour when taken with a fatty meal. Tadalafil absorption is not impacted by food. None of the PDE5 inhibitors are affected by alcohol ingestion, although alcohol ingestion is associated with erectile dysfunction. Tadalafil also has a half-life that is 3 times the length of the other PDE5 inhibitors, with the duration of effect up to 36 hours. Metabolism: PDE5 inhibitors are metabolized through the CYP450 systems, CYP3A4, so caution is to be used when taking other drugs metabolized through the same pathway. interactions. The PDE5 inhibitors potentiate the hypotensive effects of nitrates, alpha blockers, and other antihypertensives. They're contraindicated with nitrate use because they potentiate the risk of severe hypotension. Plasma levels are increased by CYP3/4A inhibitors such as ketoconazole, itraconazole, erythromycin, grapefruit juice, and protease inhibitors. Levels are decreased by rifampin, which is an inducer of the CYP3A4. Use caution, avoid in patients with active peptic ulcer, predisposition to priapism, recent history of stroke, recent history of MI within the past 6 to 8 weeks, significantly low blood pressure, uncontrolled high blood pressure, unstable angina, cardiac failure, severe liver impairment, end-stage renal disease that requires dialysis. Side effects: headache, flushing, dyspepsia, dizziness, nausea, nasal congestion, rhinitis, altered vision, back pain, myalgia. Module 8, Unit C. Osteoporosis. More than 40 million people in the U.S. have osteoporosis or have low bone mass that puts them at high risk for the disease. Vast majority are women, especially postmenopausal. 50% of women older than 50 will suffer one or more fractures related to osteoporosis. Preventive strategies are essential and include diet high in calcium, regular bone strengthening exercise, calcium 12 to 1500 milligrams daily, and vitamin D 800 to 1000 IU daily. Supplementation as needed, and reduction in modifiable risk factors such as smoking, alcohol intake of more than 2 drinks a day, high caffeine intake, high calcium and vitamin D intake, physical inactivity. Primary osteoporosis is caused by age-related bone loss. Secondary osteoporosis is medication or disease-induced. Patients on chronic steroids, androgen deficiency, hypogonadism, anorexia or bulimia, gastric bypass, celiac disease, hyperthyroidism, ankylosing spondylitis, rheumatoid arthritis. Pharmacological agents. The most common medications are anti-resorptive drugs that decrease the bone-destroying activity of osteoclasts and include hormone therapy, bisphosphonates, selective estrogen receptor modulators, rank ligand inhibitors, calcitonin. Parathyroid hormone is also an anti-resorptive agent. But its mechanism of action is activation of osteoblasts. The goal of pharmacologic therapy is to prevent fractures which are associated with high morbidity and mortality. The mode of action of these drugs involves reduction or cessation of bone loss, support of bone strength, reduction or elimination of fractures. Regardless of the treatment method selected, a DEXA scan should be performed every 2 years to assess efficacy. FYI, cost variance between products is extensive, so when prescribing, it is essential you consider the cost-benefit ratio. Generic alendronate costs less than $100 a year, $2,000 for Vista or Prolia, and $15,000 for Forteo. Biphosphonates, first line for postmenopausal women with low bone mineral density and as preventive measure and for treatment. For postmenopausal women with osteoporosis include alendronate, Fosamax, risedronate, Actonel, ibandronate, Boniva, zoledronic acid, Reclast, and Aclasta. Regimens range from daily to weekly to monthly interval dosing. Biphosphonates increase bone mass density at the spine and hip and reduce fracture risk. Candidates must be screened for low serum calcium and adequate kidney function before initiation. Low serum calcium or inadequate glomerular filtration rates are contraindications. Although many women take biphosphonates indefinitely, this is not advised. Controversy exists regarding the safety and necessity of long-term use. Alendronate, which is Fosamax, does not prevent many more fractures after 5 years and may be harmful. Currently, men and women who are considered low risk for fractures should consider discontinuing biphosphonates after 5 years. Those at high risk may consider for a longer time period. However, FDA has not determined the safest length of time. Clients also need to take calcium and vitamin D with biphosphonates for maximum effectiveness. Side effects: possible damage to the GI tract, specifically the throat, esophagus, stomach. Rare but severe side effects may include a typical fracture of femur and hips, esophageal cancer, osteonecrosis of jaw due to reduction in blood supply to the jaw. Therefore, patients may be unable to have dental implants while on biphosphonates and should notify their dentist when they are taking this medication. Patient education: take with full glass of water after rising. Do not lie down for at least 30 minutes after taking. Can lead to esophageal ulceration. Take on empty stomach or 4 hours after eating, and do not eat or take other medications for at least 30 minutes after taking. Contraindications: inability to sit upright and esophageal motility disorders. SERMs, such as estrogen agonists/antagonists, bind to estrogen receptors and create an agonist or antagonist effect at the site. Although the exact mechanism of action is not known, SERMs reduce osteoclast activity while reducing the estrogenic effect on breast and endometrial tissue, thereby reducing breast cancer. Raloxifene Evista binds to estrogen receptors in bones and becomes an estrogen agonist at the site, and is the one SERM approved for both prevention and treatment of osteoporosis. However, raloxifene has only been shown to prevent spine rather than hip fractures. Raloxifene may be a good choice for a woman in her 50s or 60s with high breast cancer risk. It reduces risk if taken up to 5 years. Use after menopause, but do not treat menopausal symptoms. Increase the risk of DVT. Adjunct treatment of estrogen receptor positive breast cancers. Rank ligand inhibitors. Denosumab Prolia is the only drug in this class and works by binding to rank ligand inhibiting osteoclast formation, function, and survival, thereby preventing osteoclasts from resorbing bone. It's given via injection every 6 months. Risk factors are infection of the abdomen, urinary tract, and ear. Bone-forming treatment: teriparatide, which is Forteo. It's a parathyroid hormone analog, the only medication on the market that promotes bone formation for men and women. Due to high-risk side effect profile reserved for extreme cases for patients with a high risk for fractures. Hormone therapy, estrogen and progesterone, may be used to reduce risk of fractures and osteoporosis in specific populations of postmenopausal women. Increased risk of heart disease, DVT, breast and endometrial cancer. Hormone therapy is contraindicated in women with breast cancer or those at high risk. Women in whom estrogen is contraindicated. History of uterine or ovarian cancer. History of cardiovascular disease or stroke. History of active clotting disorder. Undiagnosed vaginal bleeding. Other hormones: calcitonin, miacalcin is not first line, but it stops bone loss and maintains bone mass, but does not rebuild bone mass. May reduce spinal fractures. Unit D, glucocorticoids and DMARDs. Glucocorticoids are named for their effects on glucose metabolism, yet they have an effect on virtually every cell in the body. They affect glucose metabolism, production, and utilization, influence lipid metabolism and fluid and electrolyte balance, affect immunological, bone, gastrointestinal, neuropsychological, and developmental processes. Glucocorticoids are most commonly used to suppress immune function in conditions such as asthma, COPD, allergic reactions, severe pain, rheumatoid arthritis, active inflammatory bowel disease, unresponsive to first-line therapy, and relapsing multiple sclerosis, as well as other autoimmune conditions. Glucocorticoids are the mainstay for treatment of otherwise fatal inflammatory conditions such as lupus. Glucocorticoids are also associated with many adverse effects. The prescriber should carefully consider the associated risks. Some notable side effects include altered metabolism, may lead to hyperglycemia with short-term use, and protein wasting and increased lipid deposition with long-term use. Altered immune response. This may be one of the medication goals, yet this effect will also mask signs of infection. Impaired bone health will cause calcium to leach out of bones and could increase osteoporosis with long-term use. Skin may thin the skin with topical use on a daily basis. Chronic use may exacerbate acne. Neurological impacts, cranial nerve palsy. Mood instability may cause tremor, hunger, agitation, aggression. Cardiac may increase hypertension due to fluid retention associated with its impact on excretion of potassium and retention of sodium in water. Ocular angle closure, glaucoma, and cataracts with long-term use. Cataracts, ophthalmosis, and papilledema. Chronic use. Hypothalamic pituitary adrenal axis suppression. Cushing's disease, osteoporosis, immunosuppression, skin changes, including atrophy, striae, telangiectasia, and acne. Considerations in patient education, minimize side effects with careful patient monitoring and implementation of preventive measures, including the use of lower potency agents and the lowest effective dose required for management of underlying condition. Patients should be informed about the adverse effects associated with systemic corticosteroid use and implement lifestyle modification strategies that may help reduce the risk of these treatments. Poison ivy or oak may require 14 to 21 days of treatment. Take with a full glass of water after food at the same time per day and keep doses to 20 milligrams or less at a time. May need to dose more than 2 times a day to avoid GI upset. To taper allows the adrenal glands to resume their normal function. Prednisone 40 milligrams for 5 days, a dosing regimen often used for acute asthma exacerbations, can be discontinued without a taper. If dosing regimen is less than 40 milligrams for 5 days, no taper is required. For longer therapy, reduce dose by 2.5 to 5 milligram decrements every 3 to 7 days until dosage is at 2.5 milligrams for 3 days, at which point patient may discontinue. Pregnancy and lactation, preterm labor, corticosteroids such as betamethasone and dexamethasone are recommended for women between 24 and 34 weeks gestation who are at risk for preterm delivery within a week. A single intramuscular course, which includes more than one dose, is given to help fetal organs mature and decrease the incidence and severity of neonatal respiratory distress syndrome. Topical corticosteroids may be used in pregnancy if safer alternative treatments have failed. One of our basic pharmacology prescribing rules comes into play with steroid use in pregnancy. Lowest dose for the shortest amount of time. Avoid use beyond 2 weeks due to systemic absorption. There are times when an oral corticosteroid, such as prednisolone, category C, is needed for severe PUPS, puerpetic, urticaric, papules, and plaques of pregnancy. Most often, it is only needed for a limited period of time. This medication should be tapered over several days if utilized longer than 1 week. Otherwise, no tapering is necessary. Low doses of systemic steroids for short periods of time are considered safe with breastfeeding, and topical low-dose steroids are probably safe. If high or prolonged doses of either route are necessary, consultation is advised. With the exception of extreme situations, the benefits of continuing to breastfeed will likely outweigh the medication-associated risks. Prednisone is considered compatible with breastfeeding. High-potency topical steroids should never be applied on or near the nipple, face, or genital area. Rheumatoid arthritis and disease-modifying anti-rheumatic drugs, DMARD. Advanced practice nurses, depending on their location and patient access to rheumatologists, may initiate disease-modifying anti-rheumatic drugs in their patients with RA to reduce permanent joint destruction and subsequent immobility. Most commonly, a rheumatologist initiates the medication, and then the patient is followed by the nurse practitioner for routine care. It is important to know the potential side effects in order to monitor patient tolerance and safety during this process. Used to reduce joint destruction in rheumatoid arthritis. Early initiation of this drug is essential in order to prevent irreversible damage. Ideally, treatment is started within 3 months of diagnosis. The healthcare provider must be knowledgeable about these medications and encourage the patient to follow the treatment plan. And the treatment plan must be followed to reduce disability. Methotrexate, Rheumotrex is first line for rheumatoid arthritis. Folic acid antagonist affects leukocyte suppression, which decreases inflammation caused by byproducts of cell degradation. Highly effective, achieves 70 to 75% improvement in symptoms within 3 to 8 weeks. Contraindicated in pregnancy and breastfeeding women and those with leukopenia. Side effects: leukopenia, thrombocytopenia, GI effects, oral ulcers, hepatic and pulmonary toxicity. Other rheumatoid drugs: sulfasalazine, which is azolfidine, hydroxychloroquine, which is Plaquenil, and leflunomide, which is Arava. Newer DMARDs are the biologic disease-modifying anti-rheumatic drugs that are derived from organic sources, target multiple factors that contribute to RA joint destruction. Tumor necrosis factor inhibitors, etanercept, Enbrel, infliximab, Remicade, adalimumab, Humira, golimumab, Simponi, and certolizumab pegol, which is Cimzia, produce a rapid response within days to weeks and are typically used as adjuncts to first-line drugs, are extremely expensive. Module 8, Unit A, Treatment of Obesity. Screening guidelines for obesity. The U.S. Preventive Services Task Force recommends clinicians screen children 6 years of age and older for obesity and offer or refer them to comprehensive intensive behavioral interventions to promote improvement in weight status. Grade B recommendation. The recommendation for screening adults is that all adult patients should be screened for obesity, and those who are obese should be offered intensive counseling and behavioral interventions to promote sustained weight loss. Grade B recommendation. Screening tool, use body mass index, BMI, screening intervals. No specific recommendations are given for intervals for screening, but the assumption is that children and adults will be screened annually during routine office visits. Targeted population. The NIH recommends weight loss support for everyone who's obese, everyone who's overweight, everyone who has an increased waist circumference, and 2 or more cardiac risk factors. BMI of 25 to 29, overweight 30 to 39, obese 40 and greater, morbid obesity, waist circumference. Men greater than 40, women greater than 35 inches. Health risks of obesity: overweight, BMI 25 to 29, and obesity BMI greater than 30 is a growing health problem, resulting in increased risk for diabetes and its sequelae, cardiovascular disorders, particular types of cancer, infertility, sleep apnea, GERD, depression, joint mobility problems. Overweight and obesity in all but a few health conditions is the result of ingesting more calories than are burned every day. The major causes of obesity epidemic can be identified as increasingly sedentary lifestyles, lack of portion control, and high caloric foods. Overview of overweight, obesity treatment, lifestyle. Caloric restriction and increased physical activity is the mainstay of any health promotion counseling and its first line of treatment. However, the impact of healthcare provider education and support for lifestyle changes has not achieved desired long-term results. Often, obesity is a difficult subject to approach with clients and requires effective communication strategies free of bias, right exercise, prescriptions. Pharmacotherapy. Consider drug therapy for patients who have a BMI greater than 30 or greater than 27 with diabetes. There are two broad categories of medications available at this time for promoting weight loss. Those that are central acting, that act centrally, and those that act peripherally. Centrally acting appetite suppressants. Phentermine and diethylpropion are Schedule IV drugs. Act as sympathomimetic amines, which mimic amphetamines. Increased norepinephrine, which increases satiety, results in short-term weight loss, yet studies reveal that weight returns quickly after discontinuation. It is for short-term use only. However, recent studies of off-label use suggest that these may be used to maintain weight control for a longer period of time. In fact, new phentermine and topiramate combination drug, Quizmia, is approved for chronic weight management. Adverse effects: addictive potential, hypertension, psychosis, tachycardia, tremors, euphoria, dysphoria, headache, GI complaints. Specifics: phentermine for short-term use, addiction potential. Phentermine and topiramate ER. Combined a stimulant with the medication known to cause appetite loss. Mean weight loss with 2-year trial is 10.5%. New drug generics not available. However, a prescription could be written separately for both topiramate and phentermine. Lorcaserin or Belvic is a serotonin 2C agonist that targets the satiety center of the brain. Only modestly effective. Average weight loss of 5.8% after 1 year. Peripherally acting anti-obesity medications such as orlistat, Xenical, Ali are over-the-counter. Induction of lipid maldigestion. Patients should take a multivitamin containing A, D, E, and K and beta-carotene 2 hours before or after orlistat or at bedtime. Take orlistat within an hour of each meal containing fat. Adverse effects: gas, oily spotting, fecal incontinence, cholelithiasis, abdominal or rectal pain, nausea, hepatitis, pancreatitis. Off-label meds used or studied for weight loss: bupropion, Wellbutrin, Zyban, exenatide or Bieta, zonisamide or Zonegrin, HCG, thyroid hormone. Surgery. At present, the most effective means of significant and sustained weight loss for obese patients is bariatric surgery. Gastric bypass patients typically lose 30% of weight, while gastric binding patients lose approximately 20% of weight. A meta-analysis of studies related to bariatric surgery demonstrated that effective weight loss was achieved in morbidly obese patients through surgery. Patients who undergo gastric bypass surgery will have altered absorption of oral medications. Reduced surface area for absorption. Drug solubility is altered. Tablets require dissolution and disintegration, which may impact absorption. Reduced hydrochloric acid and reduced intestinal enzymes result in altered medication absorption. To account for these changes, prescribe alternate formulations such as liquid, injectable, transdermal, rectal, vaginal, and intranasal. If a tablet is the only formulation for the med, avoid extended release and sustained release formulations. Patient education. Calcium absorption is reduced. Rapid weight loss after surgery can lead to gallstones. Lifelong B12 supplementation recommended. Oral medications not well absorbed. There's an issue with many meds. Could make oral contraceptive pills ineffective. Pregnancy and obesity. The prevalence of obesity is rising in developed countries, making pre-gravid overweight one of the most common high-risk obstetric situations. Although the designs and populations of published studies vary widely, authors agree that pre-gravid overweight increases maternal and fetal morbidity. Even moderate overweight is a risk factor for gestational diabetes and hypertensive disorders of pregnancy, and the risk is higher in subjects with over obesity. In 2009, ACOG issued guidelines for management of obesity in pregnancy and conditions related to pregnancy after bariatric surgery. And that's it.